Let's talk defensive medicine in psychiatry. When doctors feel threatened by potential complaints or litigation over outcomes they perceive as beyond their control, they adopt defensive strategies to protect themselves from legal action rather than strategies that benefit the patient. Defensive medicine can include unnecessary tests, referrals, documentation, hospital admissions, coercive interventions, overdiagnosis, and avoidance of patients with complex conditions. In the context of psychiatry, Brown and Rayne in their 1989 paper provided a case study example of a 68-year-old man with no history of mental illness, arrests, legal difficulties, substance use, or psychiatric treatment, who was held for just over 20 days after a threat of legal action was made by the man's family, should he have been discharged and harm his wife. Throughout his admission and clinical evaluations, while there was evidence of violence towards his wife, there was no evidence he was mentally ill or cognitively disturbed, and while discharge was planned, upon receiving notification of the family's position, the hospital held large meetings inclusive of the hospital's legal team and rescinded the man's discharge. The case is presented as an example of defensive psychiatry, where the patient's civil liberties and autonomy were actively infringed upon for non-medical purposes. Brown and Rayne identify sharp increases in involuntary detention of mentally ill people any time a violent crime by a mentally ill person is publicly reported, and suggests this is caused by clinician fear and them being held liable if something goes wrong. Of course, liability is still possible when a patient is wrongfully detained under the mental health legislation. However, these cases are significantly less likely to be pursued and are generally perceived as a lower monetary threat to clinicians and hospitals. While patients are significantly more likely to be wrongfully detained under mental health legislation for fear of them harming themselves or others, the evidence actually suggests that suicide risk assessments and other risk formulation tools used in psychiatry are not only potentially causing harm to patients, but are non-reflective of suicidality 95 to 99.8% of the time, meaning that suicide risk assessments are only accurate a maximum of 5% of the time. Because of this, Lundahl in 2024 argued that suicide risk assessments are an example of a ritual clinicians engage in that is non-evidence-based, that serves a non-medical symbolic social function of uniting healthcare workers, fostering a sense of safety and control over suicidal behaviour, projecting accountability, and signalling to the public that action is being taken to address suicide rates. Regardless of empirical data demonstrating suicide risk assessments and other risk formulation tools lack clinical significance, hospitals across Australia and the world still use them to inform decisions of clinical care and whether or not to hospitalise a patient. The 2025 paper by Wyder and co. found rates of involuntary hospitalisation in Queensland had consistently increased regardless of the legislative intent of the Mental Health Act 2016 to reduce involuntary treatment, and identified through interviews that clinical staff in a Queensland hospital were placing patients under the Mental Health Act because of medico-legal fears like those identified in the 1989 and 2024 papers, which, to be clear, should be considered examples of defensive psychiatry that opposes the patient's best interests and infringes upon the patient's right to decision-making, their autonomy, dignity, freedom of movement, with the potential impacts on patients, including them experiencing restrictive practice, inclusive of physical restraint and medication restraint, financial fallout due to their inability to work, impacting housing security and job security, and the patient's ability to access appropriate healthcare in the future because of the stigma and discrimination within health services against patients with a recorded mental illness. Any act of defensive medicine is a failure of clinical decision-making and medical ethics, compounded by the failures of senior clinicians, their non-clinical supervisors, and oversight bodies that consistently fail to recognise that these acts are occurring, regardless of the research demonstrating that it is in fact occurring and is a breach of medical ethics. The sources for this are Brown and Rayne, published in 1989, titled Some Ethical Considerations in Defensive Psychiatry, a case study published in the American Journal of Orthopsychiatry. The 2025 paper by Lundahl titled Suicide Risk Assessments Understood as Medical Rituals, Functions and Implications from Societal and Medico-Ethical Perspectives, published in Bioethical Inquiry. And the third paper by Sawhney, Wyder, Sebar and Gill in 2025, titled Reasons Behind the Rise in Involuntary Psychiatry Treatment under Mental Health Act 2016, Queensland, Australia, Clinician Perspectives, published in the International Journal of Law and Psychiatry. The links for all of those papers will be in the description of this video.